It is an absolute honor, a pleasure. It's a privilege for me to be here speaking on behalf of ACCP and ASHP on adult acute leukemias and myelodysplastic syndromes. My name is Anthony Personati. I'm a clinical pharmacist specialist at the University of Michigan. Here's my disclosures. Objectives are also listed here. Ultimately, my goal is to help simplify acute leukemias and MDS for you all so that you can pass your BCOP exam and or recertification. My goal is not for you guys to walk away becoming experts and knowing everything about acute leukemias and being able to debate between one standard of care versus another standard of care. But if that is your goal, I am here till Saturday, and I would be more than happy to nerd out with you day and night about acute leukemias. And nobody ever takes me up on my offer, but the offer stands until Saturday. So we'll start off with MDS. So the way this presentation will go, and for those of you in the back, I don't have a timer here, so and I love to talk about these disease states, so I'm guaranteed to go over my 90 minutes unless I'm shown my time. So I'm going to start talking about myelodysplastic syndromes, move into AML and ALL, and I do this strategically because I do like MDS, but I really, really like AML, and I absolutely love ALL, and so it's a way for me to keep my momentum throughout this presentation. And in life, if I had to give a hierarchy of my loves, it would be my family, probably next Taylor Swift, and then ALL, appropriately so, right? Lots of head nods. So I think the best way to understand myelodysplastic neoplasms, it is no longer called myelodysplastic syndromes because the WHO felt as though syndromes was not scary enough and does not articulate that it is a cancer. But they are in fact a cancer, and therefore it is now MDN, but that doesn't roll off the tongue, so we just kept it as MDS still. So the best way to understand what MDS is by taking a look at a patient here. So CJ is a 69-year-old female with no past medical history, presents very commonly significant fatigue. Blood work's done by her family physician. Neutrophils are normal, hemoglobin is low. Platelets are relatively normal at this time, and so she's transferred over to a hematologist where we performed a bone marrow biopsy. And this is where we start to understand the diagnosis of MDS. So when we go in and we take a look at our patient's early progenitor cells, we see dysplastic changes. So essentially these cells look funny looking under a microscope. The nuclei look like lava lamps, and these cells are not functional. And so this will lead to a bone marrow that is not quite functional. So starts with anemia, can then end up with neutropenia and thrombocytopenia. Some things that are important on this slide that you should kind of circle are ringed sideroblasts and then this SF3B1 mutation. So when it comes to treatment decisions, these two things will come into play, and so that's why I want you to circle those. I would never have you circle cytogenetic abnormalities, molecular abnormalities, unless it requires some thought and thinking about how they will impact your patient's treatment. So in this case, this patient has a low-risk IPSS revised score. Her EPO level is 150. What do you all think is the most appropriate treatment at this time? Would it be decitabine, lenalidomide, epoetin, Atgam with cyclosporin? And the poll is open. By a show of hands, how many of you all think that this is decitabine? I got a couple. Lenalidomide. One or two. We're in a room of about, what is this, like 70 people? Epoetin. Lots of hands up. We're like 90% of people hands up. Atgam, cyclophosphamide, none. And so for this answer, yes, the right answer here is epoetin. And this is changing, unfortunately. I put this on very strategically because, yes, this was the old standard of care, and technically this is still an appropriate option, but if I would have put another drug on here, luspatercept, that would have been more correct. I cannot put EPO and luspatercept on here necessarily, although I can, but that would be a very tricky question. And I'll tell you how to decipher between how to use EPO versus luspatercept as I go through the data, and the data will make it clear. So in MDS, our goals are to improve our patients' blood counts. We want our patients not to be confined to our infusion centers, coming in and out for blood transfusions, platelet transfusions. We also want to prevent things that matter to patients, like prevent them from bleeding or prevent them from getting infections. Ultimately, we really want to improve our patients' quality of life, so that requires us to reduce their symptom burden, but we also don't want them to be burdened by the treatment that they receive. Of course, our goal is to cure these patients. Unfortunately, we don't cure many of these patients, and the only way to cure these patients are with an allogeneic stem cell transplant, for which we only give for higher risk patients with MDS, and I'll show you some algorithms. The prognostic scoring systems, there are a lot of tables out there that you can use to identify how many points your patients get, and the higher the amount of points your patients get, the higher risk their MDS is. I don't think it is nice to make you calculate an IPSS, because it's just pure memorization. But what I want you to understand is what actually goes into the scoring systems. So if you have a patient that has pancytopenia, odds are they have higher risk MDS. If you have a patient that their blast percentage is very high, 13, 15% blast, they probably have higher risk MDS. And other things that go into it, molecular abnormalities in your cytogenetics. So after we calculate this score, we assign the prognosis based off of that score. The higher your score, generally the more symptomatic the patient is, and the worse your survival, and the more likely you are to transform to AML. Ultimately, you're creating this scoring system so that you know whether or not your patient has lower risk MDS or higher risk MDS. Every single time that I create a question for your research questions, I am always, always, always going to say this patient has lower risk or they have higher risk, because it's a waste of your time to have to calculate all these IPSS scores. Everybody can do it. Everybody can Google it and then pick what cytopenias they have or whatnot. So I'm just going to give you it. What I think is most important is for you to understand that lower risk patients get treated one way and higher risk patients get treated another way. And for our lowest risk patients, we use growth factors. So this is like that patient case, epoetin, luspatercept. We'll use lenalidomide in very specific scenarios. For patients with hypoplastic MDS, which I'll go through, we use immune suppressive agents, and then when all else fails, we'll use our hypomethylating agents. So our EPO agents, they don't really improve our patients' overall survival, but they can reduce our patients' transfusion burden. Ultimately, our goal is to get our patients' hemoglobin up to about 10 to 12. And our EPO agents only work if your EPO level is low, okay? And this makes sense. Let's think about this intuitively. If you have high EPO, giving more EPO is not going to do anything. If your patient has low EPO levels, of course, giving more EPO may benefit your patient. So low EPO equals an erythropoietin-stimulating agent. Where do we draw the line in the sand? Roughly about an EPO of 500. So in that patient case, I gave them an EPO level of 150. So EPO would be appropriate for that patient until the COMMANDS trial came out with luspatercept. This was a randomized controlled trial of patients that were ESA, erythropoietin-stimulating agent, naive, and they had an EPO level less than 500. So these are patients that we would presume that would respond well to EPO. They are randomized to luspatercept or epoetin alpha. The primary endpoint was reduction in transfusion burden, essentially. So in this study, you can see with the darker blue here that patients were more likely to be transfusion independent if they got luspatercept compared to epoetin. And so because of this study, luspatercept is now approved in frontline lower risk MDS that irrespective of their EPO level, whether it's greater than 500 or less than 500. So greater than 500, automatically they're going to get luspatercept. Less than 500, you could argue between luspatercept and epoetin, but based off of these data, this would still signify likely that you would use luspatercept. That's the FDA approval. I'll show you NCCN guidelines because they are a bit more restrictive on how they use luspatercept. Luspatercept is also approved in patients that have received an erythropoietin-stimulating agent but has failed, okay? And so this was based off of the Medalist trial, where patients, after they've already received an ESA, epoetin, they were randomized to luspatercept or placebo, and then we wanted to know what patients were likely to become transfusion independent. And you can see here that in this setting also, so again, erythropoietin stimulating agent, either non-responsive or unlikely to respond, the standard of care would be, okay, you got EPO, next line would be luspatercept. Except there's two little things that I want you to, again, remember. Remember how I made you circle ring sideroblasts? And I made you circle SF3B1? Those are incredibly, incredibly important predictors for response with luspatercept. So much so that even though the FDA doesn't really care in the front line, NCCN does really care. And so from NCCN perspective, you're only going to use luspatercept if they have ring sideroblasts greater than 15% or ring sideroblasts greater than 5%, and they have an SF3B1 mutation. And I understand that many of this is very confusing, and I will go over an algorithm very shortly to kind of put all these data together for you. This is a question that if you can answer this right, and if you can understand all the reasons why all the answers are wrong and why patients shouldn't get the certain therapies in their case, you don't need to study MDS anymore and you can move on. So this is a really important question. So according to the NCCN guidelines, which of the following patients is receiving an appropriate therapy for their MDS? A 73-year-old with newly diagnosed lower risk MDS with deletion 5q receiving azacitidine. A 67-year-old female with higher risk MDS with 12% blasts receiving luspatercept. C, a 58-year-old male with newly diagnosed hypoplastic MDS receiving epoetin. Or D, a 61-year-old female with newly diagnosed higher risk MDS undergoing an allo transplant. And it looks like the poll is working now. Perfect. Look at you guys. This is great. So absolutely, it's a patient that with higher risk MDS. Higher risk MDS equals transplant unless the patient cannot get a transplant. And so just going through the above, so deletion 5q. Whenever you hear deletion 5q, I want you to remember lenalidomide. Again, that's one of those cytogenetic abnormalities that is testable because it has a treatment associated with it. Deletion 5q equals lenalidomide. Higher risk MDS, never associate higher risk MDS with luspatercept. Luspatercept is only used for lower risk MDS. Hypoplastic MDS. Hypoplastic MDS is not responsive to EPO. They need to be treated like aplastic anemia, which is immune suppressive therapy. All right, again, deletion 5q equals lenalidomide. This slide, done. Immune suppressive therapy. Hypoplastic MDS equals immune suppressive therapy. Immune suppressive therapy equals ATG, cyclosporin, steroids, and L-Traumapag. So again, hypoplastic MDS equals immune suppressive therapy, done. Our hypomethylating agents, we do use them in lower risk MDS only after they failed all other therapies. So again, that's a summary. Hypomethylating agents, only use them if they failed all other therapies. Or they have more than anemia. So if you have a patient with anemia, thrombocytopenia, and neutropenia, making their hemoglobin better is not helping your patient. You need to also get the disease under control, and the only way of getting the disease under control is treating the disease, and that's with your hypomethylating agents. So this is really what you should try to understand. Do not memorize. Everything that I just taught you has really led up to this moment in this slide. If you understand the data that I presented, you don't have to review any of the slides that I just showed you, and you could go immediately to this slide. Again, deletion 5q, lenalidomide, the whole left side of this algorithm, done. The challenge here is that a couple of weeks ago, the NCCN guidelines, of course, updated their guidelines. And so some of this now is now changed. We really need to blow up this whole thing and sort of start from scratch here. So let's do this together. So if you don't have deletion 5q, so that's this section in the middle, this is complicated. So if you have a SF3B1 mutation, and don't look at the slide because it's not there. If you have an SF3B1 mutation with greater than 5% ring sideroblasts, or you have greater than 15% ring sideroblasts, you are now going to use luspatercept, irrespective of your EPO level. So that patient that I first put together, even though their EPO level was 150, you're going to use luspatercept if it was an option in my patient case, okay? Now, if you do not have an SF3B1 mutation or your ring sideroblasts are not greater than 15%, at that point, you will then look at your patient's EPO level. And if your EPO level is less than 500, give EPO. If your EPO level is greater than 500, move on, because they're not going to respond to EPO. And at that point, you would then again look at the ring sideroblasts, and if they're hitting this threshold, then you would use luspatercept. If all of the above is not true, their EPO level is high, they don't have ring sideroblasts, at that point we might consider lenalidomide, but honestly I would scratch this out because yes, to the people that do this every day, it's an option. From a test perspective, I would just move on, and at that point you would then move on to this other area where your hypomethylating agents are. And this kind of brings us into higher risk MDS, where you don't have luspatercept, you don't have EPO, you don't have immune suppressive therapy, and you're mainly going to be using either transplant or a hypomethylating agent. And even though intensive chemo is on there, scratch it out. I have to put that because that's what the NCCN do recommend, so it has to be there. But from a testing perspective, it is way too controversial to use intensive therapy for these patients. So again, from a testing perspective, scratch it out. So hypomethylating agents are a preferred choice, but this is only if patients can't go to transplant. Let's move on to this algorithm. This algorithm is a little bit easier, okay? All you have to ask yourself is my patient a transplant candidate? If the answer is yes, get them to transplant. If the answer is no, use a hypomethylating agent. And that's azacitidine or decitabine. Technically, azacitidine is preferred. But this is a Coke versus Pepsi type debate where they're both appropriate, but you have strong opinions about it. And then as far as transplant candidates, you have different ways of getting there. Ideally, if you can get your patient to transplant right away, send them to transplant right away. Don't wait around. But oftentimes the donor is not ready. And so at that point, we would start a hypomethylating agent and then bridge them towards transplant. And again, this bottom one, just scratch it out. High intensity chemo, none of us are doing this in practice, although yes, it is a recommendation by the NCCN. But just simplify things. Go to transplant, go to transplant, go to transplant. How you get there, if it's going to take a while, bridge them with a hypomethylating agent, but get them to transplant. That is MDS in a nutshell. So it's gotten a lot more complicated because of luspatercept. If you know where to use luspatercept, you're going to be fine because all the other puzzle pieces will fall together. You'll know where to use EPO, you'll know where to use your hypomethylating agents. So let's talk about AML. So RO is a 44-year-old female, and they're newly diagnosed with AML. They're NPM1, FLT3 ITD, and FLT3 TKD mutation negative. Cytogenetics reveals a translocation 821. Which of the following is the most appropriate to initiate RO at this time? Would it be A, 3+7 with venetoclax, B, 3+7 plus gemtuzumab, C, liposomal cytarabine daunorubicin, or D, azacitidine and venetoclax? All right, so I'm glad that most of you answered the question wrong, and that's okay. And I understand, because of venetoclax. Venetoclax is the hot and sexy drug that everybody wants to use, and yes, in AML, that is the thing to do. But one piece of information that is super important is the translocation 821. I'll talk about what this is, but it's super important. Again, it's another translocation that dictates how you're going to treat patients. And so in these patients, we would use 7 and 3 plus gemtuzumab. Right now, venetoclax should only be used with a hypomethylating agent or low-dose ARC. It is currently not used with intensive chemotherapy, so that's why that's wrong. Liposomal cytarabine and daunorubicin is used for secondary AML. Azacitidine and venetoclax is absolutely appropriate for an older patient without favorable risk cytogenetics, which translocation 821 is. AML, how do we make the diagnosis? So MDS, technically, to make the diagnosis of MDS, you have less than 20% blasts. And then once we go through that line in the sand of going above 20%, now you are AML. That is sort of the old way of thinking things, and there's a lot of turf wars between the WHO and the International Consensus Classification, which is not really consensus at all, but the ICC argues that maybe you don't need 20%. For your purposes, because it's controversial, I would say that AML is defined as blasts greater than 20% unless they have specific cytogenetic or molecular abnormalities that by definition equals AML. And these are listed right at the bottom here. The ones I think are fair game for you to know are translocation 821, like the case that I just showed you, inversion 16, translocation 1616, which is essentially inversion 16. Collectively, 821, 1616, inversion 16 are what we call our core binding factor leukemias, and they should get gemtuzumab with 3+7. So that's important. The next couple, 15, 17 is APL. We'll talk about that. You should know that. But these next couple, NUP214, MRTFA, no, scratch those out. Yes, they're important to know. Yes, they define AML, but they're not testable. I can't remember half of these mutations myself, and I do this every single day. So it shouldn't be testable. KMT2A probably is, because this is the MLL rearrangement. So it is important. But MECCOM rearrangement, no, scratch it out. NUP98, scratch it out. Again, they define AML, but I wouldn't test you on that. NPM1, though, is something that I do think is potentially testable. So your core binding factors, your KMT2A, your NPM1 patients, you should know those, mainly because they define AML. Second, they can dictate treatment. And then thirdly, they dictate prognosis as well. So the way that we treat AML is we take a look at our patient's age, performance status, and comorbidities, and based off of this, we determine if our patient can tolerate an intensive 3+7 or a less intensive regimen like venetoclax and a hypomethylating agent. The other way that we can treat AML is based off of if they've had secondary AML, meaning it was secondary from either a prior MDS or a prior CMML, or it was secondary from receiving their breast cancer therapy like adriamycin. So treatment related or from an antecedent hematologic disorder, we would classify those as being secondary AML, and there's a drug for that. That's why I'm belaboring this so much, because it does impact treatment. That's where we would give liposomal daunorubicin cytarabine or CPX 351. So this is our Holy Bible that we, according to the ELN, that we use every single day. And it helps us, again, with treatment decisions. NCCN wants this rushed within roughly about a week so that you can make proper treatment decisions. But most importantly, it helps us with prognosis. And the prognosis is what dictates who is going to go to a transplant versus who can be consolidated with chemotherapy. So our favorable risk patients, consolidation is just with chemotherapy, but our patients with intermediate risk and adverse, they require a bone marrow transplant. So the core binding factor patients, I've told you to memorize. The NPM1, I told you to memorize. Favorable risk, no transplant. But this adverse group, this is really tough to memorize, and there's a lot of them. And so I guess what I would memorize is FLT3 is bad, FLT3 equals transplant, and I would remember P53, because whenever the question is on your test, whether it's my disease or somebody else's disease, P53 is always bad. And so that would require a transplant as well. The rest of these, personally, I would take a hit on them because it's too much to memorize. I think if you memorize FLT3, P53, and the good risk cytogenetics, the core binding factors, I think you will do really well on the test. So AML, when our patients come in, they come in with potentially hyperleukocytosis or even hypoplasia, and we have to prevent our patients from dying from these complications in the first 96 hours or so. So they can come in with DIC, disseminated intravascular coagulopathy, where they can bleed and clot, and we have to give them blood products like fibrinogen, cryoprecipitate to prevent the bleeding and clotting. We also have to bring down their white count, and we'll bring it down usually with hydroxyurea. And while we're bringing cells down, we can see tumor lysis. Within my handout, if you want to learn all about tumor lysis syndrome, it's within the handout. Infection risk is also something that can lead to mortality. We have an entire section on febrile neutropenia that is in the non-live presentations. So when patients present, essentially we have the pathologist look at the cells under a microscope, and they can help us identify, does my patient have AML or do they have ALL, or maybe they have another type of leukemia, CML or CLL. So they can kind of tell under the microscope which type of cells based off of what they look like. But the gold standard is flow cytometry, where we're firing lasers on the outside of the cell to tell us what are the clusters of differentiation, or the CDs on the outside of the cell. And that's going to tell us exactly, oh, this is AML, or this is ALL, or CML, or CLL, or the other alphabet soups of the leukemias. So flow cytometry defines how we identify AML versus ALL. And while all this is going on, we send off those cytogenetics that I showed you and the molecular testing so that it can help us identify treatments, but also our patient's prognosis. When the patient walks through the door, I would highly recommend, if you practice in the setting, go see your patient, because we have scoring systems that can help with a patient's fitness. Most of us do the eyeball test. We go in our patient rooms and we look at them and we say, yeah, you can tolerate intensive chemo, or no, you can't. Again, most of us don't use scoring systems to be able to do this. It's really the eyeball test. Fit patients are going to get intensive chemotherapy. Non-fit patients, older patients, going to get less intensive chemo. And ultimately, our patients stay with us for a month. They go through a month of cytopenias, and at the end of the month, hopefully they count recover and they have no signs of leukemia, and that's what we would call a complete remission. Age can be one way to stratify whether your patient can get intensive chemo versus not. The NCCN specifically states an age cutoff of 60, but many of us who practice in this field give intensive chemotherapy to patients that are 65 or older. So age is not a mandatory cutoff. And so when you see these test questions, we have to be very obvious. A patient, performance status of 3, a patient that can't get out of bed, versus, a patient's been running 12 miles per day, right? We have to be very obvious to tell you this patient is fit or they're not. And just by saying, we have a 62-year-old female, blah, 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 there's no way for you to identify whether the patient should get intensive. So we have to make it egregiously obvious for you. Otherwise, it's not a fair question. Of course, we want to integrate predictive biomarkers as well. So it is important to understand the drugs that target specific kinases. Our FLT3 inhibitors, midostaurin, and quizartinib, which are used in the frontline setting, and then gilteritinib, which is used in the relapse refractory setting. And then sorafenib is used in the post-transplant maintenance setting. And then we have IDH1 inhibitors, an IDH2 inhibitor, and then gemtuzumab that targets CD33. Now, one red herring that I tend to put in my test questions is I will put a patient with one of these mutations And just because the mutation's there doesn't necessarily mean you have to use one of these drugs. And I'll show you some examples. And a prime example is an older patient, say 76 years of age, and I'll put a FLT3 inhibitor, say quizartinib, single agent, frontline, and then I'll put HMA-VEN. And everybody will gravitate because they'll say, oh, FLT3 inhibitor. I know the FLT3 inhibitor, I'm going to pick it. But HMA-VEN would actually be more appropriate for that patient, and I'll show you some of that. But again, I just want to reiterate, just because a mutation is there does not mean you absolutely have to pick the drug that targets the mutation. So it's important to know when to use these drugs and when not to use the drugs. And the fact that CD33 is positive does not mean that you should use gemtuzumab. So the standard of care since 1973 has been 7 and 3. We've tried to add to things. Some things we've improved, but unfortunately we still use this backbone after half a century. We've tinkered around with the dose. It's incredibly controversial. I won't get into it. I strongly believe 90 should be used, but the NCCN guidelines recommend 60 to 90. And so therefore, it doesn't matter what I care about or what I think or my interpretation of the data. All that matters is what the national guidelines say, and they recommend 60 to 90 milligrams per meter squared. And so if you have an answer that says 45, wrong. If it's 60, right. If it's 90, it's right. So like I said, we've added to 3+7. One of this has been in our FLT3 positive patients. So this is a scenario where if you see FLT3 positive, add a FLT3 inhibitor. Why? Because the RATIFY trial showed an overall survival benefit when you add midostaurin to 3+7. So this was a randomized controlled trial of midostaurin with 3+7 versus placebo and 3+7. The primary outcome was overall survival, and we did indeed show an overall survival benefit with using midostaurin. Some things that I think are important is to know the toxicity profile of midostaurin. Despite what they saw in the clinical study, nausea is actually incredibly challenging for some of our patients. So I will tell my patient, take a Zofran before taking your midostaurin, and you do this twice a day. Some patients feel as though it tastes like a skunk, and I live in Ann Arbor, and so they describe it as an herbal substance that they often take as well. So, very nausea-prone, rash is a possibility, and then the drug interactions. I bring this up not to tell you how to manage the drug interaction, mainly to tell you that this is controversial. Everybody will disagree. I see some leukemia pharmacists here in the crowd, and I can guarantee you that he or she will disagree of how to manage this drug interaction. Some might switch to micafungin. Some might do dose reductions on the midostaurin. Some might not do any dose reductions and just, hope for the best and play roulette and hope that toxicities don't happen. And so because of that, I bring this up because I don't want you perseverating over this drug interaction. We know it's a drug interaction. We have no idea what to do, and so I would not test you on what is the best approach of this drug interaction because it's controversial. Again, like I said this morning, controversy is a good thing for you all because we can't test on it. The Quantum First study is another study of quizartinib, so similar population as RATIFY. Young fit patients for intensive chemotherapy, they get 3+7 or quizartinib, or they get 3+7 with placebo. The unfortunate thing about this study is that nobody in this room now knows, should I use quizartinib or should I use midostaurin because of the study. Therefore, I cannot ask you a question of FLT3 positive AML getting 3+7 with quizartinib or should they get 3+7 with midostaurin. I can't ask that question from a therapeutic perspective because they're both right answers. This also led to an overall survival benefit when adding quizartinib, so it is a standard of care. Now, one way that I could phrase my question is I could set this patient up with, a poor cardiac history. They already have a QT that's, 550 or something like that. Or I have a patient that I'm incredibly worried about the myelosuppression. And so I could set this up as a question of, yes, there's no difference, or I don't know if there's a difference in efficacy, but there are some patient-specific things from a toxicity profile that could sway you to a better answer versus not. And so if I was to write a FLT3 question, That's how I would write the question. Not for you to pick what is the more effective drug, because we don't know, but I would push you to know what the side effect profile is between midostaurin and quizartinib, and that's why I put all of that information on the slides. Secondary AML. This is a randomized controlled trial of older patients, but fit, where patients with secondary AML, remember those are patients that previously got some chemotherapy that caused leukemia, or they had a prior hematologic disorder like MDS or CMML, and now they have AML. This is a study of secondary AML where patients got CPX-351, which is a liposomal formulation of 3+7, versus 3+7. The primary outcome here is overall survival. In this study, CPX-351 improved overall survival, and as such, it's now an FDA-approved NCCN recommendation. And so if you have a patient with secondary AML on the test, if that pops up, pick CPX-351 or liposomal daunorubicin cytarabine. Do not pick 3+7. Is that what I do in real life? Well, we're going to have to nerd out over coffee after, and we can talk more about that. The toxicity profile, a lot more myelosuppression with CPX-351 and potentially some bleeding. Okay, this study and the next following studies are going to answer that question that I asked you with that patient with a translocation 821. Why did I choose gemtuzumab? Why did I not use 3+7 with venetoclax? This is starting to tell the story of gemtuzumab. So this is the Alpha 0701. These are older but fit patients being treated for AML, and they were randomized to receive 3+7 or 3+7 with gemtuzumab. And I want you to remember something else for about 3 minutes, and then you can erase it from your minds. But, the specifics I want you to erase from your mind, but the general principle I don't want you to. So consolidation here. Consolidation after you've got 3+7 and gemtuzumab is intermediate dose Ara-C with daunorubicin and gemtuzumab. So that specific, remember for 2 minutes, and then we'll erase it from your minds, and then I'll tell you the general principle of how we use consolidation. And it'll make sense. You're probably thinking I'm crazy right now. What is he talking about? It'll make sense in a couple of minutes. So in this study, gemtuzumab improved event-free survival. It did not improve overall survival in this particular study. Here are some of the toxicities that you should know about. Gemtuzumab can cause sinusoidal obstructive syndrome. You'll learn all about this in your BMT chapter. And there are more cytopenias and also bleeding and liver toxicity with gemtuzumab. So we have to be very thoughtful of patients that we want to use this medication in. So what happens, you got your stats lecture, and I agree wholeheartedly, overall survival is the endpoint that I care about. I don't care about EFS, quite frankly. This study, the Alpha study, did not improve overall survival. So why do we use gemtuzumab? Well, many would argue, well, if you don't have an overall survival benefit, perhaps it was just underpowered, right? So what do we do in underpowered studies? Well, we take a bunch of studies, we throw them into a meta-analysis, and we hope for the best. Well, this meta-analysis by Hills and colleagues did exactly that. And in this meta-analysis, they found that patients with favorable risk cytogenetics, this is why I wanted you to remember what a core binding factor is. I didn't do it just because I think it's cool. I did it because it has treatment implications. So a core binding factor, again, your 821, inversion 16, translocation 1616. Look at the overall survival benefit. There is an overall survival benefit, and as such, the NCCN prefers this as your regimen of choice here. Again, we can talk offline about critically appraising meta-analysis and things like that, but it's not my opinion that matters, it's the NCCN guidelines that matter. And so if you have a core binding factor leukemia patient, you should absolutely positively use gemtuzumab because it is NCCN's preferred regimen for favorable risk. And they go even a step further. It's not even cytogenetics. They'll even say the molecular too. So your NPM1s and your CABP alpha. That to me is controversial. Is it testable? I don't know, it's controversial. But I think what is very testable is a core binding factor patient should get gemtuzumab. For others that are fit, 3+7 is your standard of care. For secondary AML, this is young patients. Technically, 3+7 is correct. I think that would be a mean question. Yes, the CPX study was primarily in older patients, and yes, we have data to show that 3+7 does just fine, even if you have secondary AML. But I think for testing purposes, personally, I would scratch out the 3+7 there and just put in your mind secondary AML equals liposomal. If you go back to the clinic and you have fun discussions with your hematologists and pharmacists, don't scratch that out. But for testing purposes, that's what I personally would do. And then lastly, all the way to the right, FLT3 positive AML, you have to add a FLT3 inhibitor. There's an overall survival benefit. Which one, midostaurin or quizartinib? Your guess is as good as mine. One thing that we could ask you, so midostaurin has activity against not just the internal tandem duplication, but also the tyrosine kinase domain. There are two types of FLT3s, TKD and ITD. Midostaurin has activity for both. Quizartinib only has activity for the ITD. So another test question I could write is a patient has FLT3 ITD. I'll put quizartinib, I'll put midostaurin. Only midostaurin is correct because quizartinib does not have activity against the ITD. The TKD. All right, so this is what I wanted you to memorize for 2 minutes and then erase from your memories. So 10 days following confirmation of complete remission, RO is to receive consolidation or post-remission therapy. Good kidney function, good hepatic function. Which of the following should this patient get? Azacitidine, venetoclax, intermediate dose cytarabine, daunorubicin, and gemtuzumab. Remember, this is a core binding factor leukemia patient. C, liposomal daunorubicin, cytarabine, or D, 5+2. Excellent. By show of hands, how many would you, if I didn't tell you to memorize this answer, how many would have gotten this? Not many, right? So you don't have to memorize this piece. The general principle that I do want you to memorize is that if you started with some form of induction, you should follow that consolidation through. So for example, if you did azacitidine with venetoclax, you're going to consolidate or do maintenance with azacitidine and venetoclax. If you gave gemtuzumab up front, you would do gemtuzumab as consolidation. If you gave liposomal daunorubicin cytarabine, you would do as consolidation daunorubicin cytarabine. 5+2, personally, I don't think should ever be done. If you're doing 3+7, the standard of care would be high-dose Ara-C. And we'll go through consolidation. So consolidation essentially means you're trying to consolidate the remission. Okay? Induction, you're inducing a remission. Consolidation, we want to consolidate the remission. So the patient's in a remission, we're trying to deepen the remission. There are two forms of consolidation. Either we can do chemotherapy consolidation, and remember, chemotherapy consolidation is for patients with favorable risk cytogenetics or molecular. And then all the others, we do allogeneic stem cell transplant as consolidation. So as far as which ones to pick, like I said, if you do 3+7, the standard of care is to do high-dose Ara-C consolidation. Things that you should know about high-dose Ara-C, it can cause cerebellar toxicity. So all of us, when we're giving our patient high-dose Ara-C, we're doing the finger-to-nose test. We're doing the sobriety test, right? Having them write their name, making sure that they still have their fine motor skills. Have them walk in a straight line. So cerebellar toxicity, and then the ocular toxicity, keratoconjunctivitis. This is the reason why we give steroid or saline eye drops to our patients during therapy and 2 days after. So those are the two toxicities of high-dose ARC that you should know. And then, again, like I said, depending on the regimen that you would use, this is the general principle that I want you to memorize, is if you started with a specific regimen, continue it. Don't worry about, oh, they used intermediate dose plus daunorubicin plus gemtuzumab. Focus on more so the gemtuzumab or the liposomal daunorubicin or the venetoclax with HMA. This brings us into our third, and this is a relatively newer phase of therapy in AML. Previously, we always used to just do induction consolidation and then hope that we cured our patients or our patients would, unfortunately relapse. Maintenance is trying to maintain a remission. Now, if you want to get practice in critically appraising literature, this is one of the best studies to learn whether or not things were ethically done properly and what things you would want to do or change and critique and improve. And based off of that, would your critique of the literature, would it have changed your practice and introduced maintenance therapy? That being said, your critical appraisal, my critical appraisal means nothing to the test. All that matters is what does the NCCN guidelines recommend. And they recommend maintenance therapy based off of this study, the Quasar study. So these are patients that got intensive chemo, so they got 3+7. They may have gotten some cytarabine consolidation, they may not have. And then they were randomized to go on to either oral azacitidine or placebo. And patients were followed, and the primary endpoint was overall survival. And overall survival was improved. And because overall survival was improved, that is the endpoint that we care about. This is now a national standard to use oral azacitidine. You'll notice that the dosing, 300 milligrams orally daily for 14 days, very different than subcutaneous or IV. I think one important point, if you could highlight, circle, star, is that you should never, ever, ever substitute oral azacitidine with IV or sub-Q. IV and sub-Q, yes, but not oral. This is very different than oral decitabine. Not going to get into that, but just remember oral azacitidine cannot be switched around. So if you're doing, say, azacitidine with venetoclax, that's sub-Q or IV. You will not switch your patient over because it's a pain in the butt to keep coming into your infusion center 7 days in a row. It is not appropriate to switch them to oral azacitidine. All right, so here's a 79-year-old. Notice how old I made this patient, 79. So it's obvious that I'm not going towards intensive chemotherapy. They present with a low white count. We see that this patient has an IDH mutation. They're also CD33 positive. She lives with her husband 10 minutes away. Which of the following treatments is the most appropriate for this patient? Is it gemtuzumab, because she's CD33 positive, venetoclax by itself, azacitidine with ivositinib, or decitabine with enasitinib? All right, excellent. 75% of you got this correct. And so gemtuzumab, not the correct answer, even though that was that red herring that I'm talking about. Just because something's positive doesn't mean you have to use it. So gemtuzumab, even though CD33 positive, you don't have to do it. Venetoclax, never use that as a single agent. Single agent activity is quite low. Decitabine with enasitinib. Enasitinib is an IDH2 inhibitor. We have an IDH1 mutation. Here, azacitidine and ivositinib would be correct. Now, what if I asked you ivositinib plus azacitidine or a hypomethylating agent with venetoclax? How would you answer that? We don't know. Both are correct answers, okay? And so I could never put that on this test question unless, again, I'm coming up with some safety type stuff or, feasibility type but from an efficacy standpoint, we don't know which one is better than the other, mainly because of how the study was conducted. So previously, older patients, we used to only give them hypomethylating agents by themselves. And this used to take about 4 to 6 months before we would ever see a response. Thankfully, because of the VIALE-A study, we've moved away from just using azacitidine or decitabine by itself. So this is the reason why everybody picked venetoclax in the first place. This is such a foundational, important study that completely transformed how we treat our older patients with AML. So these are older patients greater than 75 with comorbidities. They are randomized to azacitidine with venetoclax versus azacitidine by itself. Very appropriate comparator arm, very appropriate primary endpoint of overall survival. And overall survival and event-free survival and the CR/CRI rates were remarkably improved in this very challenging population to treat. And so as such, every single person is using HMA venetoclax for their older patients with AML now. There's some pearls, though, about HMA. This is challenging. The amount of cytopenias now that you see with HMA can be very challenging. We also see faster responses. So we used to only see responses 4 to 6 months later. Now you can see a response usually within 2 cycles. Some patients, you can see responses even within 1 cycle. Specifically, a patient with an IDH mutation. That's why we don't know if using HMA-Ven versus HMA with ivosidenib is correct, because they're both exquisitively sensitive to. So we generally will get a bone marrow biopsy around day 28 and not move on to the next cycle. If you move on to the next cycle immediately, you can see some pretty prolonged durations of neutropenia. So on a day 28 marrow, if you still have disease, we get going, we start therapy. But if you don't have disease, we tend to just hold therapy, let them count recover, and then start their therapy once they count recover. The other thing that you should know is that venetoclax requires significant dose reductions if you're using it with a strong azole, which many do. Again, this is a controversial area. If you ask, again, our different leukemia pharmacists in the audience, are you using venetoclax 70? Are you using venetoclax 100? Are you using 28 days, 21 days, 14 days? You'll get a different answer. And so the take-home message is that there's a drug interaction. I think if something was on the test, I would follow the package insert, which says reduce it to 70 milligrams. So this is the AGILE study that led to the FDA approval of ivosidenib with azacitidine. Unfortunately, it did not compare it to what our standard of care is, azacitidine with venetoclax. So this is why all of us are unsure of, do I use ivosidenib with azacitidine or do I use azacitidine with venetoclax? Again, both of them are going to be perfectly appropriate options. You see an overall survival benefit here, an improvement in CR, CRH, and an improvement in event-free survival. And so as such, the NCCN has recommended it as a preferred option for patients with IDH mutations. Some things that you should know is the QT prolongation and how to monitor for that. You should also know that it can cause differentiation syndrome. We'll talk about this in APL, but these are new drugs. Ivosidenib, enasidenib, olutasidenib, even our FLT3 inhibitors, gilteritinib and potentially quizartinib, can all cause differentiation syndrome, which is unique. Usually you always just thought atra and arsenic caused differentiation syndrome. There are drug interactions as well, and interestingly, both ivosidenib and olutasidenib are inducers. And so if you start posaconazole or voriconazole on patients that have ivosidenib, this data was just published by one of my colleagues, Caitlin Rausch, leukemia pharmacist, showed that our azole levels are incredibly low because ivosidenib is inducing the metabolism. So something that you should consider doing TDM in your practice on. So olutasidenib, same position as a single agent as ivosidenib. It does not have an approval right now in the frontline setting, and it does not have approval in combination. So if you're ever to use it, it would be as a single agent. Here's a chart that essentially just shows you some of the differences of these different agents. The easy one is IDH2 inhibitor is enasidenib, and then you'll see the differences between ivosidenib and olutasidenib. But again, I think the biggest take-home point is ivosidenib can be used in combination with AZA in the front line, whereas olutasidenib is not. It's used as a single agent. So this is what NCCN recommends. So if you don't have an actionable mutation, you're going to use venetoclax with azacitidine based off of the VIALE-A. That being said, if you have an IDH1 mutated patient, if you have an IDH2 mutated patient, even if you have a FLT3 mutated patient, HMA venetoclax, perfectly appropriate. And so again, I would not be able to make you pick between aza-ven versus ivo azacitidine. And again, everything that I went through the clinical trials are all listed here. But again, I don't want you to, be pigeonholed and say, oh, my patient has an IDH1 mutation. Oh, Anthony didn't put any IDH inhibitor, what do I use? HMA-ven is perfectly appropriate in those patients. All right, so let's move on to relapse AML. So this is a patient that's followed a clinical trial with CPX-351 and gemtuzumab, and now is relapsed. The patient has no molecularly targetable options. Which of the following is the most appropriate for SB? Would it be midostaurin, FLAG-IDA with ivositinib, MEC, or gilteritinib? All right, excellent. You guys already know AML. Why are you guys here? You didn't need to learn this stuff. So MEC, yeah. So midostaurin, FLT3 inhibitor, ivositinib, IDH inhibitor, gilteritinib, FLT3 inhibitor. Patient has no targetable mutations, can't use anything. The standard of care would be some form of chemotherapy. Now, how do you pick between the different chemotherapies? We don't know. It's controversial and therefore not testable. I could not put MEC as an option. I couldn't put FLAG also, or FLAG-IDA, GCLAC, GCLAM. These are based off of phase 2 data, no randomized controlled trial data to say one is better than the other, and therefore all of them would be perfectly appropriate, and it's all institutional specific. But what you want to do is always in relapse refractory AML is resend off your cytogenetics and molecular, because it can change, and therefore we would then want to ideally see if we can use a targeted therapy. The reason why gilteritinib got FDA approved was based off of the Admiral study. So these are patients that got, let's say 3+7, and they got high-dose Ara-C consolidation maybe, or maybe they were refractory after 3+7, but ultimately they ended up relapsing. What do we choose? Well, back in the day, we would choose for a FLT3 positive AML patient, a MEC or FLAG-IDA. This study wanted to challenge the standard of care and say, hey, should we use a FLT3 inhibitor, gilteritinib, or should we use our standard of care, MEC, FLAG-IDA, or for patients that can't tolerate those therapies, azacitidine or low-dose Ara-C? So this study's primary endpoint was overall survival, and gilteritinib prolonged overall survival. And so as such, gilteritinib is now an FDA-approved drug for relapse refractory AML. So to summarize our FLT3 inhibitors, frontline, quizartinib or midostaurin with 3+7, no gilteritinib in the front line. Gilteritinib in a patient that is relapsed after chemotherapy. I think it's an open question how well it works after receiving quizartinib or after receiving midostaurin, but for all intensive purposes, gilteritinib would be the correct answer as single agents. And I'll just leave it at that, and I know there's a lot of institutional differences on how to approach that scenario. As far as toxicities, LFT abnormalities we can see, and I'd say most of our patients, if they're going to have toxicities, it could be the myalgias of the LFT abnormalities, but for the most part, it's well tolerated, minus the cytopenias. The cytopenias can be quite profound. So cytopenias are the biggest issue that we see in practice. And like I said, we can see differentiation syndrome with gilteritinib as well. So AML, summary. Decide if your patient is fit for therapy. If they're fit for therapy, give them 3+7. If they're core binding factor, add gemtuzumab. If they have a FLT3 mutation, add quizartinib or midostaurin. If they have secondary AML, you're going to use liposomal daunorubicin cytarabine. If they're an older patient, it's essentially HMA-ven Or if they have an IDH mutation, you might do HMA with ivosidenib. Consolidation, remember the general principle of just follow what the study did and follow what therapy was kind of given in the front line. And then oral azacitidine is an option for patients with intermediate or high-risk cytogenetics who got into a CR and they're not a candidate for allotransplant. The other subtype of AML that I want to talk about is acute promyelocytic leukemia. This is a disease state where on your test question, you might not get the diagnosis. They might not upfront tell you your patient has APL, but they may tell you that they have translocation 1517, or they might not even tell you that it has 1517 at all, and they might say that your patient is presenting in profound DIC. Their fibrinogen is down low, they're presenting with a stroke or a bleed or a clot, and they'll ask you, what is the most likely diagnosis? APL. The first 96 hours of a patient with APL can be life-changing. You must start ATRA immediately under any suspicion of APL. Okay, so if you see that test question, even if they don't give you the answer of this is APL, if you see DIC and ATRA is an option, start it immediately. And so, because it's essentially, it's going to help reverse all of that DIC that's occurring. Important thing for you to know from a treatment perspective is what high-risk APL is and everything else. You don't need to memorize the platelet count and what low and intermediate risk is. You need to know what high-risk APL is, because high-risk APL gets treated differently than low intermediate risk APL. And this is because of a study by the Lococo published in New England Journal of Medicine, where they only used non-chemotherapy approach, just ATRA and just arsenic. ATRA and arsenic are differentiating agents. The toxicities are listed here. And so for high-risk APL, you have to use some form of chemotherapy. So it can be ATRA plus something else, and that could be ATRA plus arsenic, but it has to be chemotherapy. So you have to add either idarubicin or gemtuzumab. So high-risk APL equals add-on chemotherapy. You can't just do ATRA and arsenic per guidelines. For lower intermediate risk, you can do that. You can just use ATRA and arsenic, done. And that's because we have close to 100% overall survival in low intermediate risk patients based off of this, the APL 406 study. And so because of that, none of us use chemotherapy anymore for low or intermediate risk patients. So ATRA and arsenic would be your gold standard. Again, if this was a high-risk patient, add gemtuzumab or add idarubicin. All right, so this is a patient, LJ, started on ATRA, arsenic, gemtuzumab for high-risk APL. So there it is again, chemotherapy added to ATRA, arsenic, appropriate for high risk. On day 15, white blood cell count is 0.1, but their biliary is starting to increase. They're getting a 10% weight gain. They have painful hepatomegaly, and here's the piece that you should really take note of. They're developing ascites and a reversible portal flow on ultrasound. What is the best thing that is describing this patient's symptoms? Is it coagulopathy, urosepsis, sinusoidal obstructive syndrome, or differentiation syndrome? I absolutely love hearing the whispers in the crowd right now, because you have the answer. All I heard was, it's C. It's C because of gemtuzumab. So that's exactly why. Gemtuzumab can cause sinusoidal obstructive syndrome. Now, if I would have removed the reversal of portal flow on all the ultrasound findings, that is differentiation syndrome until proven otherwise. But I specifically put that in. And also, I specifically put this here to then make you think, oh, the next slide is differentiation syndrome. But you guys didn't fall into my trap. Perfect. You guys are thinking. This is fantastic. So yeah, differentiation syndrome is something we see with ATRA and arsenic. The first signs of differentiation syndrome is weight gain. You'll see absolutely no symptoms, and I tell my interns and residents every single day, monitor your patients' weights that are on atropine and arsenic. You're going to see that their weights go up 3 pounds, 5 pounds, 6 pounds. They have no symptoms at all. And then I tell them, okay, well, just oscillate their lungs now and listen really closely because I know you haven't actually been listening. And of course, guess what happens? Their lungs are starting to fill up with fluid. They're starting to see a lot of peripheral edema. Well, that can escalate very quickly. All of a sudden, they have a leukocytosis, and they're on oxygen, and then they're on their way to the ICU. So the way that we treat this is with steroids. This is a phenomenon where cytokines are being released, and so we want to temporize those cytokines by using dexamethasone. And in severe scenarios, or even in moderate scenarios, hold your differentiating agents. This is a marathon, not a sprint. You are going to cure nearly 100% of your APL patients. You don't need to get them onto a ventilator and try to save them in the ICU. You can prevent that from all happening by just stopping their drugs, letting things settle down, and then reintroduce them. They're all going to go into remission. So you stopping the drug is not going to get them out of remission. Now, you might push them back into DIC, and so it might be a balancing act, but ultimately stop the drugs if you're in a challenging situation. So APL, to summarize, low intermediate risk patients, atropine and arsenic. High risk patients have a white count that's 10,000 or higher. Use chemotherapy with your differentiating agent, gemtuzumab or idarubicin. Is what is recommended in the NCCN guidelines. So last but not least, acute lymphoblastic leukemia. So DH is a 55-year-old male, complains of bone pain, early satiety, headaches, comes in with a white count of 80,000 with 40% blasts, diagnosed with Philadelphia chromosome negative B-cell ALL. Which of the following is the preferred NCCN recommendation? Is it the CALGB 10403? Is it the CALGB 9511, Hyper-CVAD, or ECOG 1910? Oh no, Hyper-CVAD. So Hyper-CVAD, you're right. So that's what most people probably used to do. For an older patient, you don't want to use asparaginase. And so you're moving completely away from like a pediatric inspired BFM-based backbone, and you use Hyper-CVAD. And also Hyper-CVAD's easy, right? You don't need to follow these massive 500-page protocols. You can just go A, B, A, B. It's part A, it's part B, and you just go back and forth, and it's easy, right? And so a lot of people do inappropriately, unfortunately, use too much Hyper-CVAD. And I think the NCCN were bold and they were smart, and they have downgraded Hyper-CVAD for adults with ALL, primarily because of the new ECOG 1910 study. And so that would be the answer. And I'll go through what the ECOG 1910 study is very shortly. So the way that I think about ALL is, at least from a treatment perspective, is we've got B-cell ALL and we've got T-cell ALL. And then within our B-cell ALLs, you've got Philadelphia chromosome negative, and you've got Philadelphia chromosome positive, or PH positive, or BCR-ABL positive. The second way that I think about the treatment of ALL is by age. Adolescent young adults, age, this is a fluid age, 39, 45, whatever, but we'll just say 39 for argument's sake. And then in adults, 40 to 60, and then older adults, greater than 65. So cytogenetics are incredibly important. I used to have a very big table that showed you all the cytogenetics. I took it out because I didn't want you memorizing it. But cytogenetics are very important because that's what helps us decide who should go to transplant versus not. And the second thing that is incredibly important is that pH status. So if you're pH positive, not only are we going to use a tyrosine kinase inhibitor, but we might think about the type of backbone that we're using as well. So that translocation 922, that's something you have to memorize. Dr. Fancher is going to talk all about CML, But don't forget that also Ph-positive ALL can also have that Philadelphia chromosome, that translocation 922. And it's important from a predictive factor because we add a tyrosine kinase inhibitor, but it's also important from a prognostic perspective. Historically, they did poorly, and we used to take all these patients to transplant. This has likely changed due to the TKIs, incredibly controversial and therefore not testable. But the NCCN guidelines, for those that really care, would only transplant patients with Ph-positive disease if they have something called an Icaros plus mutation or IKZF1 mutation. And this just went over probably everybody's head, so don't worry because it's not testable. So as far as treatment, this is part of the reason why so many people are scared of understanding ALL, but part of the reason why I love ALL so much, because it's so confusing. There's so many phases, and this is the pharmacist's dream for physicians to not know what they're doing, because that provides a role for all of us. It is incredibly, incredibly complicated. Now, here I've broken it up into 3 phases, but many of our BFM backbones actually have 5 phases. We have induction, phase 1. We have consolidation, phase 2. We have interim maintenance, phase 3. We have phase 4, which is intensification, and then phase 5, maintenance. And there are even blocks within those blocks to make it even more complicated. And so incredibly, incredibly complicated. And that's why a lot of people will use hyper-CVAD, because they can at least count the alphabet up to B, A, B, A, B. And so a lot of people will just use hyper-CVAD. So again, we choose the regimen based off of the Philadelphia chromosome, but also those ages that I delineated: an adolescent young adult, an adult, and an older adult. For adolescent young adult patients, the emphasis is away from myelosuppressive therapies. So we use less daunorubicin, less cytarabine, less high-dose Ara-C, less high-dose methotrexate, and we focus on things that are more lymphotoxic: steroids, vincristine, asparaginase. And asparaginase is an incredibly challenging drug to use. I have some tips and tricks of how to use this drug in my handout if you are interested in learning more about it. So inductions, usually we build it upon usually an anthracycline, vincristine, steroids, and then maybe some asparaginase. So why the shift over the last 10 years of using adolescent young adult regimens or pediatric-inspired regimens? This came because Wendy Stock had a bet with her pediatrician. She said, she's an adult treater. She said, hey, if I treat my 16-year-olds on my adult protocols, I guarantee you I'll have just as good outcomes as you. You're a pediatrician treating with your pediatric regimens. Unfortunately, Wendy was dead wrong. Her outcomes were worse. Even though she knew what she was doing and knew how to treat ALL, because her regimen was an adult regimen, her outcomes were worse. So overnight, well, actually it took a lot more than overnight, but Wendy then started the C10403 trial, and she tested in a phase 2 study to identify how do patients, adult patients or adolescent young adult patients, how did they do with pediatric type regimens? And indeed, it was a little bit more toxic, but the outcomes were a lot better than historical controls, a lot better than what Wendy would have ever done with an adult-based regimen. And therefore, we no longer encourage, and the NCCN does not prefer anything but a pediatric-inspired regimen for our adolescent young adult patients. And you can see here event-free survival is improved. So certainly we would love to have a randomized controlled trial. The ECOG 1910 study, and this is the answer to that question that I had previously, this is a wonderful randomized controlled trial. These are hard to conduct in ALL, but God bless they did it. So this is a patient population aged 30 to 70. So remember, our patient was like, I don't remember, 53, 55. So that patient meets this inclusion criteria, and they were Philadelphia chromosome negative, not positive, negative, okay? They got their courses, and this is why I sort of went over course 1, 2, 3, 4, 5. After course 3, after interim maintenance, they were randomized, if they are MRD negative, measurable residual disease negative, to either blinatumomab or just go on to our regular standard of care. And our regular standard of care was either continue with chemotherapy, or if you were high-risk cytogenetics molecular or MRD positive, go on to allotransplant. This is a remarkable, remarkable overall survival benefit. I wish I was allowed to, plagiarize and put in the survival curves and not have to pay for the copyright, because I would love for them to be there. It is a plateau. It is a straight line, meaning that we are curing, roughly about 70% of our patients, a very hard to treat population. Now, mind you, it's an enriched population, but what you should take away from this is that blinatumomab should be used for virtually all patients now with Philadelphia chromosome negative ALL. That's MRD positive, that's MRD negative, and yeah, that's everybody. So this is how NCCN marks out how they would treat ALL. So adults greater than 65, scratch all that out. It's so controversial, we can't ask you a question about that. Adults less than 65, I just asked you a question about that. It's ECOG 1910. Done. The adolescent young adult patient has to be a pediatric inspired regimen. So it can be one of these that are listed here, 10403, a Dana-Farber-based pediatric inspired regimen, or if you have T-cell ALL, you could use C10403, or you could use 0434. Now, what I want you to also write down is 0434, you cannot use for B-cell ALL. Okay, that's a T-cell specific protocol because it adds nelarabine. So let's move on to pH positive ALL. This is the DIALBA study. So to give you a little bit of history, none of us know how to treat, or none of us know how to agree upon how to treat pH positive ALL. You'll have some that use low intensity regimens where they might use some steroids, vincristine, plus a tyrosine kinase inhibitor. You'll have others that will use a hyper-CVAD based backbone with a tyrosine kinase inhibitor. And so both of them are correct. So the take-home message for you is you don't need to pick which backbone to pick. What you need to pick is identifying what is a BCR-able tyrosine kinase inhibitor. You also don't need to pick imatinib versus dasatinib versus bosutinib, nilotinib, or ponatinib, because none of us can also agree, and we don't have data to say that one is better than the other. I certainly have my preferences, but from a testing perspective, we can't make you pick one versus the other. So from a test perspective, if you have pH positive ALL, start a TKI, backbone, it doesn't matter. What we're now trying to study is, can we move away from using as much chemotherapy? So this study was the DIALBA study, a phase 2 study where blinatumomab and dasatinib was used with minimal chemotherapy. Some patients did go to transplant. And at 4 years, roughly about 75% of our patients were cured, which is a remarkable feat for a diagnosis that we used to consider poor risk and used to have an overall survival of less than 20–30%. Patients that did a little bit worse were those patients with an Icaros plus mutation. So those are patients that we would still consider to take to transplant. So this is a lot. We can't test on this. I mean, it makes it easy for me because I have to make test questions that are just egregiously wrong. Like I would put a question like, hey, patient with pH positive ALL, and an option would be like R-CHOP, RCVP, right? And you would look at it and be like, well, those are lymphoma regimens. So don't get tripped up about that. Yeah, I mean, we would have to make things very wrong. So something very wrong would be a pH positive patient without a tyrosine kinase inhibitor. Okay, so it always has to have a tyrosine kinase inhibitor. But how to pick between blinatumomab with TKI, steroids with TKI, hyper-CVAD plus TKI, how to pick between nilotinib, bosutinib, et cetera, who knows? All of them are technically options per the NCCN. So I talked very briefly about measurable residual disease. What exactly is that? So measurable residual disease is, we do a patient's bone marrow, we take a look at it under a microscope, and we do not see any blasts. But we know that there's still disease. And so we'll use more sophisticated tests like PCR, next generation sequencing, flow cytometry, and we'll try to detect disease at 1 to 10,000, 1 in 100,000, 1 in a million. And that is measurable residual disease. Another way of thinking about it, you have a haystack here. When I throw a needle in the haystack, there's no way I'm going to find that. But if I get a metal detector, my NGS, my PCR, my flow cytometry, I'm going to find that needle, that measurable residual disease. And so that's what measurable residual disease is. It's a sign of chemorefractoriness. So patients who are MRD positive, there is a study called the BLAST study, and because of this study, it made it very hard for us to accrue with ECOG 1910. These patients were MRD positive after several cycles of chemotherapy, and the goal here was to bring them to become MRD negative, because MRD negativity is a surrogate marker for overall survival. Ideally, I would love to do a randomized controlled trial, and I would love to look at overall survival, but there's not enough equipoise between ALL physicians that they would ever randomize an MRD positive patient nowadays to placebo. Everybody that's MRD positive is going to get blinatumomab nowadays. So if you think MRD positive, right equals blinatumomab. So overall survival, don't know exactly what this means because there's no comparator, but it looks really long. MRD negativity, very high, but again, I don't know what this means. But we're never going to know what this means because we're never going to have a randomized controlled trial. But blinatumomab equals MRD positivity, and MRD positivity equals blinatumomab. Some toxicity that you should know about with blinatumomab is cytokine release syndrome. The cytokine release syndrome is not nearly as profound as with CAR-T, but it does happen. Same with the neurotoxicity, the ICANS, or the neurotoxicity. We can also see it with blinatumomab. The incidence of these two toxicities are not nearly as high as CAR-T, and the grading is generally not as high either. And the nice thing about blinatumomab is you can shut off the infusion. Very, very short half-life. Patients are on the medication 28 days straight, and so you can shut off the drug, whereas CAR-T, you're not shutting off those T cells. If shutting it off doesn't work, we give steroids, and I'll show you an algorithm of how to treat cytokine release syndrome and also the neurotoxicity. So again, MRD positivity equals blinatumomab, but what you should also know about blinatumomab is the dosing is different if they're MRD positive versus if they have overt relapse of their disease. So here we start right up at full dose, 28 micrograms per day, whereas with relapse refractory disease, we start at 9. We also escalate the dose with the relapse refractory dose at day 7. We keep our patients in the hospital for MRD positivity for 3 days, whereas with relapse refractory, it's about a 9 to 10 day admission. So that brings me to the last piece, and that is relapse refractory ALL. So there's several agents that we could consider using. One is inotuzumab, one is blinatumomab, and then the others are CAR-T depending on your age. So tisagenlecleucel or brexacabtagene. How do we pick between these? From a test perspective, you can't. They would all be appropriate options. In practice, we'll use disease burden and prior therapies. We'll think about this methodically, but from a test perspective, all of these are correct answers. For Ph-positive ALL, we generally will send off mutational testing to see, hey, did we develop something like a T315I mutation that confers resistance to dasatinib? And then we'll consider switching around our tyrosine kinase inhibitor as opposed to completely changing around the chemotherapy backbone or potentially even adding blinatumomab at that point. But we certainly will do those as well. But generally, we consider changing the TKI if appropriate first. And then for T-cell ALL, we generally will introduce a medication called nalarabine. It's T-cell specific. So if you see T-cell, think nalarabine. The Tower study is what led to FDA approval of blinatumomab, and it showed an overall survival benefit compared to conventional chemotherapy, and that's how it became a standard of care. So what you're seeing here is blinatumomab essentially for all patients. MRD negative patients based off of the ECOG 1910, MRD positive patients based off of the BLAST study, and then relapse refractory patients based off of the Tower study. And then with inotuzumab, this is only approved in the relapse refractory setting right now. This is based off of the INNOVATE study, showed an overall survival benefit compared to chemotherapy. Inotuzumab, the second name of this on here is azithromycin. What else has azithromycin? Gemtuzumab. Exactly, gemtuzumab. So gemtuzumab and azithromycin, gemtuzumab can cause VOD. Inotuzumab can also cause VOD as well, so something for you to consider. And the VOD risk here is actually higher with inotuzumab for several factors that I won't get into. So here's a patient that was refractory to 10403, refractory to Part B of hyper-CVAD, is now admitted for blinatumomab. On day 2 of the infusion, the patient develops grade 2 ICANS. Which of the following is the best strategy to treat your patient's ICANS? Would it be A, supportive care, B, permanently stop their blin, C, tocilizumab, or D, dexamethasone? Awesome. Yes, 75% of you picked dexamethasone. Yes, absolutely. We don't need to permanently stop blinatumomab for grade 2. Tocilizumab, that would be appropriate if this was CAR T. We don't treat CAR T cytokine release syndrome the same. Our bone marrow transplanters, our CAR Ters, are deathly afraid of steroids, so they avoid it at all costs and use expensive medications like tocilizumab. In ALL, we're not afraid of steroids, and actually steroids work quite well. They're not going to completely kill all your T cells. So steroids is the most economical and I think most efficacious thing to use in this scenario. And also with ICANS, so that's for CRS. For ICANS, steroids actually is the standard of care, whether it's from blinatumomab or from CAR T. I was getting ahead of myself here. So CAR T cell, we've got tisagenlecleucel. This is approved for patients up to the age of 25 for relapse refractory ALL. And then we've got brexacaptogene, which is approved for adult ALL. Those are the main things that I want you to remember from how to pick between the CAR Ts. Are you less than 26? Tisagen. Are you an adult? Then brexacaptogene. So cytokine release syndrome, I talked very briefly about it, but what exactly is it? It's a very inflammatory cytokine release that causes anywhere from fevers, rigors, hypotension, mental status confusion, etc. And ICANS is a neurological toxicity. There are different ways that we can grade the ICANS. We typically will use the ASTCT grading criteria. And this is, the next 2 slides are what I would definitely learn. So patients with CRS, again, this is mainly for CAR T, but for CRS management, if you have persistent grade 1, you would use tocilizumab. Otherwise, you would just do supportive care. Grade 2 equals tocilizumab. Grade 3 equals tocilizumab plus dex. And grade 4 is do everything possible because this patient's in a bad place. And then for ICANS we use steroids, whether it's CAR T or whether this is bispecifics, use steroids. Tocilizumab can actually paradoxically worsen ICANS, and so we try to avoid tocilizumab here. All right, so to summarize ALL, again, you want to identify your patient's Philadelphia chromosome status. If they're negative, no TKI. If they're positive, they get a TKI. If they are an adolescent young adult, use a pediatric-inspired regimen. If they're an adult, use ECOG 1910. If they're older than that, there's not really a standard of care. Blinatumomab, remember there's 3 indications for it. Technically, MRD is not FDA approved. MRD negativity is not approved, but it's NCCN recommended. And for relapse refractory ALL, you've got Blin, you've got INO, you've got CAR T, and then don't forget about nelarabine for patients with T-cell ALL. And so with that, I don't want to overstay my time here. It's been a pleasure to speak with you guys about ALL.